Vestibulodynia, a common cause for painful intercourse, presented by the program in Vulvar Health at Oregon Health and Science University. Chapter 1. Defining vestibulodynia. Vestibulodynia is a sexual pain disorder that affects 8 to 15% of women sometime in their lifetime. It is much more common than most people realize. This condition is known by several different names such as vulvodynia, vulvar vestibulitis syndrome, vestibulodynia, and recently as localized provoked vulvodynia. Vestibulodynia is a condition that affects a small area of the inner vulva. The vulva is the external female genitalia that includes the clitoris, the urethra, which is the opening to the bladder, and the vaginal opening. The vulva also includes the vestibule, which is a small area of skin surrounding the vaginal opening, measuring less than 2 inches. Most women experience no pain when this skin is touched. However, women with vestibulodynia experience pain when the vestibule is even lightly touched. Pain is often described as burning, searing, tearing, and raw. Women with vestibulodynia often present to their healthcare provider with the concern of painful intercourse. Usually, women with vestibulodynia experience pain only with sexual penetration, like when the penis first enters the vagina. Otherwise, most women with vestibulodynia are not bothered with day-to-day pain. Women with this condition can usually wear jeans comfortably, exercise without discomfort, and enjoy all other aspects of life. Some women with vestibulodynia may have difficulty with tampon insertion or pain with speculum exams during their annual pap smear, since these activities also include insertion into the vagina through the painful vestibule. Vestibulodynia is a sexual disorder that can be further divided into 2 types, primary and secondary. Primary vestibulodynia occurs when a woman has experienced pain since the first time she tried to use a tampon, have a pap smear, or attempt vaginal intercourse. The pain has always been there. Secondary vestibulodynia occurs when a woman has had pain-free intercourse for some period of time and then later develops pain. Although the cause of vestibulodynia is unknown, new research reveals that primary and secondary vestibulodynia may be different from each other, even though women with either type experience similar symptoms. Chapter 2. Scientific investigation of vestibulodynia. Although the cause of vestibulodynia is unknown, we understand that the vestibule skin in women with this condition is abnormal. Research in the last 10 to 20 years has shown that the tissue environment is different in women with this condition. Normally, the vestibule skin is nourished by blood vessels and nerves. The sensation of touch is transmitted to the brain via nerves. In women with vestibulodynia, the painful tissue has bigger, thicker, and more abundant nerves. The painful vestibule also shows more inflammation cells than normal. We also suspect that pain interpretive center in the brain changes so that women with vestibulodynia experience light touch as searing and burning instead of soft and feathery. Researchers believe that both of these changes, increased inflammation cells and bigger, thicker nerves, lead to the pain women experience in vestibulodynia. Researchers in this field are trying to understand what leads to these changes. We believe that the trigger may be different for each woman. For example, the trigger may be a genetic predisposition, or it may be an exposure of the vestibule to an environmental irritant. It may also be a brief infection with a virus or yeast or bacteria. Finally, the trigger may be a hormonal change like menopause or postpartum. We think there may be different triggers and it may be different for each woman. Regardless, all women with vestibulodynia experience pain in the vestibule, leading to difficulty having intercourse or penetrative activities. Even though the vestibule skin is abnormal, we understand that the way the body deals with this pain is complicated. Coping with painful sex affects the emotional, physical, and psychological way the body responds to sexual cues. It also greatly affects the way couples manage intimacy. Chapter 3. Understanding vestibulodynia. We have come to understand that vestibulodynia affects 3 different areas of physical and mental health. Each part contributes significantly to the distress and pain women feel with this condition. These 3 areas of health include the vestibule skin, the pelvic floor muscles, and the psychological well-being of the woman affected by pain. First, we know that the vestibule skin is painful to touch. This is often the symptom that drives most women to seek help. Next, the muscles deep in the pelvis that surround the vagina are affected. These muscles are often clenched, tight, and sore. And finally, the emotional sexual well-being of the woman with vestibulodynia is greatly impacted. Many women feel sad and angry about their inability to have a normal sex life. Each part is equally important and often requires treatment in order for a woman and her partner to share intimacy with less pain and less distress. Each part of the vestibulodynia triad is important to address. In the beginning, most women only identify difficulty with vaginal intercourse, not appreciating the complexity of the problem. In fact, most women present to their healthcare provider with the complaint of pain at the vaginal opening during penetration. Since there is a cultural and social belief that intercourse can sometimes be painful, many women try to compensate for this pain with lubricants and position changes. However, despite these techniques, women with vestibulodynia find that the vestibule skin pain leads to challenges with maintaining intimacy. For some, sexual intercourse becomes impossible. Most women with vestibulodynia also have sore and clenched pelvic floor muscles. This is the second component of the vestibulodynia triad that contributes to physical and emotional pain during sexual intercourse. Pelvic floor muscles surround the vagina and can be voluntarily contracted and relaxed. These are the same muscles that keeps a woman from losing urine or passing gas. The pelvic floor muscles normally relax and become soft when the vagina is penetrated, easily allowing a tampon or a finger or a penis to enter the vagina. In vestibulodynia, these muscles become tight and clenched as a way for the body to protect against pain. This muscle clenching is sometimes referred to as vaginismus. During attempts at vaginal intercourse, the pelvic floor muscles involuntarily respond by withdrawing and tightening. The woman often has little awareness that her pelvic floor is doing this. This makes the vagina tight and hard to penetrate, which then adds to the pain and difficulty of having vaginal intercourse. Finally, it's important to realize the psychosexual effects of vestibulodynia. This is the last part of the triad. Women with this condition often remark on how profoundly painful intercourse has affected their ability to be intimate with their partner. Many women share that they begin to lose confidence in their ability to be sexual. Women describe feeling sad and angry about their inability to have enjoyable sex. Some women begin to feel worried every time sex is attempted, since it usually results in terrible pain and feelings of guilt and shame. Women often describe not only a loss in their interest to have sex, but also in their ability to become aroused. They worry about their ability to have children, since having intercourse has become infrequent or impossible due to pain. In summary, understanding vestibulodynia means appreciating that each part of the triad contributes significantly to the distress and pain women feel with this condition. The painful vestibule skin, the contracted and sore pelvic floor muscles, and the suffering psychosexual health all play a role in this sexual pain disorder. Women describe many ways in which their lives have been affected by this difficult condition. Chapter 4. Treating vestibulodynia. Treating this condition is often a journey that incorporates an integrated team of practitioners who are all invested in helping you have pain-free and enjoyable sex. Research supports that when each part of the triad is addressed, women have the best outcomes. Although there is no fast and easy cure for vestibulodynia, women who actively participate in an integrated treatment program often show the greatest improvement in pain. Most women with vestibulodynia have seen a number of doctors or clinicians before they receive the diagnosis. By then, these women are feeling frustrated, hopeless, and suffering. Receiving a diagnosis often feels like a relief for many women, and yet they are also very interested in learning about treatment. Through important clinical research, we have found that an integrated care model leads to the best results in reducing pain and returning women to healthy sexual function. When women first receive the diagnosis of vestibulodynia, they naturally inquire about treatment, since sex has become painful for many months or years. Both topical and oral medicines are typically prescribed. These medicines help reduce the pain in the vestibule. In addition, lidocaine is a commonly prescribed medication for women with this condition. Lidocaine is a numbing gel or liquid that can be applied directly to the vestibule to decrease the sensation of pain. In some women, numbing the skin 10 to 15 minutes prior to intercourse allows them to have comfortable sex. Another treatment for the painful vestibule skin is a localized minor surgery called vestibulectomy. Some women choose this when lidocaine or other medicines and treatments are not effective in reducing their pain. Vestibulectomy is an outpatient procedure that is performed in the day surgery unit in about 60 minutes. Each surgery is tailored to the patient so that only the painful, superficial areas are removed. Vestibulectomy is the treatment most studied in research and is associated with a 60 to 90% improvement in pain. Research has also shown that outcomes are improved when women also undergo treatment for their sore pelvic floor muscles and counseling in addition to this minor procedure. Most women with vestibulodynia need rehabilitation of the pelvic floor muscles since they have become sore. Over time, these muscles no longer function normally and retain a constant contracted state, contributing to the pain in vestibulodynia. Pelvic floor physical rehabilitation is the primary treatment for these muscles and is performed by a physical therapist who specializes in women's health problems. When a woman with vestibulodynia sees a pelvic floor physical therapist, she will carefully assess the woman's muscles of the abdomen and pelvis. After the assessment, the pelvic floor physical therapist will outline her treatment plan. This evaluation and treatment is done in a gentle, private, and safe setting where vaginal muscle rehabilitation can be done. Treatment may include muscle awareness and training, muscle stretching and massage, biofeedback, and dilator therapy. Dilator therapy is unique to pelvic floor physical therapy and is a vital part of gaining control over the pelvic floor muscles. Dilators are cone-shaped objects that are used in the vagina to help the body accommodate and rehabilitate the pelvic floor muscles. Dilator work is also performed at home, since regular interaction with these muscles allows ongoing successful treatment of the pelvic floor. Finally, many women share how vestibulodynia has affected their sense of sexual well-being and intimacy. Research supports that women who engage in counseling around these challenges report feeling more in control of their pain. Special counseling allows a woman to learn tools and skills to manage these emotions more effectively. Although many women and couples feel initially reluctant to participate in this part of treatment, almost all state that it is beneficial and worthwhile in relieving the stress and burden of this condition. Referral to individual, group, and/or couples counseling is frequently made so that a woman and her partner can begin to deal with the profound effect the sexual pain condition has had on their relationship. Vestibulodynia is a common sexual pain condition affecting 8 to 15% of women. Although the cause is unknown, the skin of the vestibule shows a greater number of nerves and inflammation cells that are likely triggered from genetic, environmental, infectious, or hormonal factors. Successful treatment of vestibulodynia includes an integrated model of direct treatment to the painful vestibule skin, the sore pelvic floor muscles, and the psychosexual well-being of the woman affected by this condition. With devotion to this care model, every woman with vestibulodynia should have the expectation that her pain will improve, and she and her partner will return to a more enriching and pleasurable sexual relationship.